Well, thank you guys for joining. This is sort of a new adventure for us. Our hope is to have quarterly meetings and more or less to facilitate connections amongst all of us internationally, those of us who are scholars and clinicians, people interested in psychotherapy, rehabilitation, and also research. Ultimately, the study of metacognition. We hope to have these every 4 months, and we have scheduled some meetings for the rest of the year. But we're hoping that all of you at some point would be willing to present and share your ideas. I'll be beginning this meeting today by talking about some recent developments. And again, the hope is to share these developments to spur interest and connections within our group. And then Ilanit will give a more formal presentation of the results of her trial for adults with psychosis recently concluded, despite the challenges of COVID at Bar-Ilan University. And at the end of all this, our hope is to have an open discussion facilitated by Reed. And here we're really interested in hearing from you all about what you feel would be useful and what these meetings might look like to promote, again, continued growth and support within our own group of people who are interested in these issues. So I thought that to begin, I would try to summarize a little bit about where we're at as a large group, which is certainly a daunting task to do. We have a history with many notable roots and milestones along the way. And it's difficult to, I think, to pinpoint exactly where we are, but I can begin by saying a little bit about where we started. And I think in some ways this work begins in a variety of places, but it is centrally interested in trying to understand the practice of psychotherapy and psychiatric rehabilitation for adults with psychosis. And ultimately to reach patients who often were seen as not needing or able to benefit from psychosocial intervention, people who really seem to need at most medication and some generic or supportive interventions. And lots of the writing and formal sort of beginnings, at least, of the use of the terms and ideas that we bandy about now really starts in Indianapolis, and it's really right after the turn of the last century. So really beginning around 2001, 2002. And seeing faces, so many of you have played roles in this at such different spots in the development of this work. And I think, what you see here as also evidenced by your presence is that there are a group of people who are engaged in daily practice with patients, but also teaching and formal research. And all of those come together in some iterative fashion to try to understand in a systematic way what's happening in psychotherapy for adults with psychosis. And in this work, not to jettison the history, not to forget the past, but also not to put old wine into new bottles, but to understand the core processes that underlie recovery in ways that are systematic, that would enable us to understand what we're doing, to identify and operationalize these processes so that other serious practitioners and scientists could grasp concretely what we're thinking and to be able to decide on their own whether these views are legitimate, and to also think more deeply with us about what's happening during these processes. Overall, we wanted more than another clever theory. We wanted something that would be useful across international boundaries and would genuinely advance the treatment of adults with serious mental illness. And of course, as evidenced by the capital M in our name, we've settled on the term metacognition to think about these processes, to think about the things that are happening in psychotherapy or in rehabilitation, that are happening as people struggle or make movement towards health in the life that's been somehow involved in serious mental illness. And so we use this term metacognition in a somewhat unique way, again, not to jettison the past, but to move it forward. We use metacognition to describe an integrative process by which all of us as human beings fit together pieces of information into a larger sense of who we are, who other people are, what our place is in the world, and ultimately, what are the challenges and possibilities that we face, and how do we want to proceed with our lives? In other words, at the heart of all of this, we're looking at the processes which enable us to make some sense of what's going on around us, and how to live our lives in ways that are satisfying and ultimately to join and participate in a larger community. This definition does diverge and overlap with other views, and I think this is a challenge for us going forward. But how do we really want to define these terms? How do we want to understand our overlap with other terms? And how do we want to continue to evolve this sort of larger construct of metacognition as we apply it? That said, this has certainly led to a slew of recent papers and all sorts of different clinical enterprises internationally. And what I really wanted to do with what little time I'm going to take up that's left is I want to talk about some of the recent highlights. And I'm only going to mention things that have been published or are about to be published in 2001 this year, although I'm not going to get to the full list. I'm not going to merely give you a list of things, but I hope to give you a feel for some different things that have gone on and maybe perhaps are things you've thought about, or at least to put them all on the same page, to think about what it is that our group is really doing. In other words, as we say in America, put your money where your mouth is. What are the papers that we're producing? What is the scholarship that we're evolving? So in terms of, I think, exciting developments for us, things that I'm proud of and make me proud to be part of the group with all of you, is that Ilanit and I have published recently an overview in World Psychiatry. It's a brief paper, but it's our most public venue yet to describe what metacognition offers us in terms of a renewed path to understanding core disturbances in psychosis and recovery. Actually, Schnackenberg Martin and I also just had a paper, actually a letter accepted in Biological Psychiatry, in which we try to refute some of the current highly cognitivist definitions of metacognition and really think about adaptation as a larger process and this larger sense of self that metacognition illuminates. There are several theoretical advances that I think are worth mentioning as well. We've published a paper in Frontiers in Psychology, thinking about social dysfunction and psychosis as more than a matter of misperception. And we use the term metacognition in this, we use our work in metacognition to really differentiate ourselves from people who want to think purely in terms of theory of mind and people misperceiving social events. In a paper in BMC Psychiatry, co-authored with Simone Kelly and Giancarlo DiMaggio as others, we also tried to distinguish social metacognition from social cognition and mentalizing. And both this Frontiers paper and BMC Psychiatry are open access, and we're hoping we'll reach a large body of researchers and make the case that our concept is really delving more deeply into subjective experience and one of these very fuzzy foundational sets of issues that underlie psychosis. The final theoretical advance I'll mention is Hugo Fulpin from Toulouse in France, has just published a paper in Journal of Nervous and Mental. And he takes the French phenomenologist Grivois and he tries to look at how metacognition might help us think about the phenomenology of psychosis, and in particular, the very specific experience of feeling as if one is at the center of all events, which is referred to by Grivois and others as centrality. We're really trying to use metacognition to think about this foundational experience in which people are not part of the larger world because the world instead surrounds them and they are detached from it. There are several new frontiers that are exciting to talk about as well. So those were some overviews and some theoretical advances. Julie Anders joined us, has a paper that's been under review at Nervous and Mental for the first time looking at patients with autistic spectrum disorder and finding some really interesting differences and overlaps in the metacognitive capacity of patients with autism and those with schizophrenia. We published in the last year our very first Russian language paper. This is published with our friends and colleagues in Moscow. And it's in the mainstream Russian medical journal called Korsakov. And it offers a lengthy overview of the constructs of metacognition and some of our emerging research as well. Simone Kelly has also published a paper very, very recently and using an Italian sample to replicate the metacognition assessment scale in an Italian sample showing good psychometrics and I think further supporting the growth of our work in Italy. There are novel directions as well. Our colleagues in Spain have published a paper in comprehensive psychiatry, looking at the links of autobiographical memory and the role of metacognition. There are a number of really fantastic clinical explorations that have also been published recently, and I can only mention a few of those. But Ilonit's group have published a paper looking for the first time at merit in an inpatient setting and dealing with the same fundamental principles, assisting people to make sense of how things have happened the way they have, how to manage them. Our colleagues in Russia have also published a case study expanding this work to patients with schizophrenia spectrum disorders in the more schizotypal personality disorder realm. Jay Ham has just had a paper that's appeared, which has delved, I think, more deeply than before in how we really relate to patients in a clinical setting. How do we really establish intersubjectivity with patients with psychosis? And what do we have to do besides being more than just open and compassionate? This gets at some of the really difficult moments and subtle moments where humor and confrontation is at play. And this is published in the Journal of Psychotherapy Integration. Ilonit also this year published a paper in Counseling Psychology Quarterly, looking at the special challenges that COVID poses for merit and detailing some fantastic and interesting observations from the work in Israel as well as in the United States. Kelsey, who's hiding in the background there, also just published a paper this year addressing negative symptoms in schizophrenia, and that has just come out. I'll also mention one of our colleagues here in Indiana, Kyle Miner, has also published in the Journal of Consulting and Clinical Psychology an open trial looking at merit and asking whether or not experience sampling might add things to that. Laura has also published papers doing analysis of some of our friends and colleagues in Montreal who have gathered data on SMI patients. She's extended the work to looking at metacognition and negative symptoms. Maybe last but not least, I'll mention that Ilonit is primarily editor on a book that's just been published by Routledge called The Recovery of the Self in Psychosis. Proud of this book and its many contributions, which include chapters by people who are here, including Kelly Buck, who continues to tell us that she's retired and not part of it, but somehow just keeps, the thoughts just keep popping up.
Yeah.
Right? Yeah, it's like lots of things. Not quite yet.
Like an old penny, maybe, Paul.
No, I'm not an old penny. So, and Kelly, of course, was part of these very early conversations in 2000, as, by the way, was Reed as we were developing some of our key instruments. So we hope that this is going to be an evolving resource for all of these meetings. We hope you will participate. We are trying to expand our presence on something called Twitter. And we have Simone and Jay working on that. We have formed, as some of you may know, a merit board who meet to try to flesh these things out. This includes Ilonit, myself, Reed, as well as Jay, Bethany, and Simone. We are continuing to update the website. We're hoping to create continuing new and lean material that makes this more accessible to people and less theoretically heavy. We're hoping to update this with videos, and at some point, we're also hoping to have a YouTube channel, and I'm hoping many of you will contribute short videos to the YouTube channel, talking about your work to connect us all. We have been working also to update the Mass A coding book and Merit If, and have created a new set of, we hope, leaner and more accessible materials for people. And again, we're hoping at the end of this to hear from you, and certainly you're more than welcome to be in touch with me or any of us offline to think about how this meeting could be helpful and useful to people. So with that, I'm going to turn this over to my friend and colleague in Israel, Ilonit, who will be sharing some details about a very exciting study that she's managed to carry out during this difficult time. Thank you.
So I'm glad we are all meeting. It's exciting, and I hope it's the beginning of a routine meeting that we'll have together to share ideas and think together. And it's nice to have the opportunity to share with you our findings. I think it's the first time that we are presenting the data on the completed trial. So it's really exciting. So I'll share with you what we did, and we'll share preliminary findings, and we would like to think together, and we would welcome any comments and thoughts and questions on our trial. So first of all, this is a very large production of those two dear students, Libby and Adi, who are my PhD students who are coordinating all these projects. And this is our team of therapists in a workshop we did with Paul a few years ago. And thanks for all these people we are having this, can share with you our findings. Okay. So some general information about our trial. So it was conducted during this time, including all the COVID-related challenges. It's as a design of a delayed randomized control trial. That means that there are people who were randomized to get married and people who were randomized to wait for half a year and then get married. And we used combined session by session assessment and pre-post treatment. That means that people also self-report or were assessed by session by session every week, short reports, and pre-post a more longer comprehensive one. And it was a 6-month therapy, and it was in a community clinic, in our university community clinic. So this is, we recruited 60 people. 6 were excluded, different reason, and then we started randomizing people. At first, we did 1-to-1 ratio, and then we saw that we have a problem in recruiting enough people, and we used a different ratio of 2 and 1. So each one has twice the opportunity to get into merit, but it was still randomized. And we have 54 people randomized, 31 were in the merit group, and 23 were in the delayed treatment. From the delayed treatment, there were 12 people who did the merit after the time of their post-assessment. So we did not include them in the comparison between groups, but we do include them in the session-by-session assessment when we want to assess the process. So we have a larger sample of all people in the 2 groups. So we had different assessment tools during screening. We did a clinical interview. People had the diagnosis of schizophrenia or schizoaffective, socio-demographic data and illness-related data such as number of hospitalization, time since diagnosis, all the routine data that we collect. The session-by-session assessment, we assessed the use of the merit elements in each session. Therapeutic alliance, emotional experience. Okay, I'll tell more about it in a few minutes. And well-being and functioning. And pre-post, we assessed the quality of life, symptoms, and metacognition and social cognition, as well as different self-related variables, additional one like self-stigma and emotional regulation and self-clarity. Okay. So now I'll briefly present different projects that are part of this large one. So the first one, we assessed how adhering to the merit elements is related to short-term outcome in the following session. In a session-by-session assessment, this was already published. And what we found, and using the TMAS to see the adherence to the different elements, and people were also reported their working alliance level that they experienced. And this, it's like this, it's in Hebrew, but this is how people reported in a computer at the when completing a meeting or before meeting. People just needed to scroll and put the level of this is an outcome rating scale of general well-being, or in an interpersonal level, in work, general one, this is how we used it. And findings show that there were two elements that showed the best outcome in the following session. Okay? If the therapist used the introduction of the therapist's mind, this is the second element, so it resulted in a better outcome at the beginning of the following session. And if there was a reflection on the progress in therapy, it was followed by a higher therapeutic alliance at the end of the same session and with better outcome at the beginning of the following session. So these were the two elements that showed the better outcome in the short term. And then when we talk about the end of the session or the next session. Okay? So this was one project. Another project is something that we are working on now is we based on the previous one that I just presented, we are doing a comparison between our sample and other people in our community clinic who cope with emotional disorders. And we wanted to see whether there are different patterns of therapeutic alliance and outcome across the two samples or between the two samples. Okay? So we wanted to check if there are differences in the diagnostic groups, in the estimation of therapeutic alliance at the beginning of therapy and patterns over time, and whether the congruence, because we have therapeutic alliance reported by the clients and by the therapist, whether the congruence on therapeutic alliance will be less frequent or less crucial on its impact on short-term outcome in one group compared to the other. And this is what we saw in the two groups. So the higher graph is for the emotional disorder and the lower one is for the merit. And the pattern is the one that we see in psychotherapy research in general of what we call and other people call and frame better safe than sorry, that the therapists always rate it lower than the clients, okay, and always as a mean of being better safe than sorry and always working for a better therapeutic alliance. So this was the pattern in the two groups. And we saw that either therapist or client alliance rating predicted better subsequent functioning in the emotional disorder group, but not in the schizophrenia group. However, we did saw this effect in the merit when we looked only on good outcome cases. We split our sample of the merit for people who showed, we used standard deviation and split the sample to good and poor outcome. And we did see an effect only in the good cases with the people with schizophrenia. We saw temporal congruence in the emotional disorder group. So therapist rating were positively correlated with the clients when over time. We didn't see that in the merit groups, but it was not significant. And the greater congruence in alliance rating over time did not predict larger increases in functioning during treatment. This is not in line with previous finding when we see that congruence is important for better outcomes. So this is something for us to think about. And these are still findings that we are struggling to interpretate. I think, Paul, we just got an email this morning from Adit that we are trying to involve you in thinking about this together. And another exciting project is focusing on emotion experiencing in our merit sample. And what we ask is, we are looking at the association between clients' emotional experience and their session outcome evaluation, the association of treatment levels of emotional experience and metacognitive growth following treatment, and whether the use of specific therapeutic elements of merit by the therapist were followed by higher emotional experience. And we are specifically here focusing on the level that the clients experience, express emotion, regulate emotion in a specific session, and how important it is to look to experience emotion and to address emotion within a session. So these were the questions, and what we found is these effects, okay? We saw these effects of emotion, experience, expression and regulation on the post-session outcome on well-being. Okay. We also saw that it predicts mastery post-treatment. So clients who presented more emotion experience, they had higher mastery at the end of the treatment. So it seems that experiencing emotion is really a crucial part in enhancing mastery. And when we check the elements, this is what we saw, the elements that are contributing to the emotional experience are, again, inserting the therapist mind, similar as the first project that I just presented. So this seems something that we really need to use. And it highlights the importance of intersubjectivity of the merit, I think. Also attention to the progress. So it's again a second time that we see this important of those elements, and the stimulation of mastery was also important in contributing to more emotional experience. I talked about the finding without this presentation. This is just a summary of what I just said. Okay. Next, now this is something we are working on these days. So this is really preliminary and we are excited to share this with you. So it's the first time we compared the group, and what we saw pre-post, the merit group and the delayed group, we saw a significant change in mastery. And almost close to significant in self-reflectivity and in other, and we need to check different maybe moderators or covariant. We still need to figure out what we can do with these two. It was completely randomized, so the differences before treatment are not clear, but I don't understand, I don't know how to explain them, but this is how it was, and it was completely randomized, so that's what we have. And we see a reduction in the mastery ability in the control group. And what is really, I think, exciting and unexpected for me, because this is something that I thought will be harder to have an effect on, is that we have significant effects on symptoms, general symptoms, total symptoms, and a very close to significant effect of negative symptoms, as you can see here. And this is the graphs, and we can see that people who were enrolled in merit, okay, their level of symptoms were reduced, okay, and it was a significant change during our trial. And in addition, we had a few other small projects from our trial. We had a case study based on data from our trial, highlighting the importance of how we can talk with people about the meaning of their diagnosis, how we can do psychoeducation while using the elements of the merit. And we also, as Paul mentioned, wrote about the challenges of this trial and another trial in the US during COVID. And what we're up to is to do an additional session-by-session analysis to look at variables that we didn't address comprehensively yet: emotion regulation, self-stigma, self-compassion. We also have. We also want to check additional results with a pre-post analysis. And just to mention, Yael couldn't join us this afternoon, but Yael is another PhD student who is running an trial in an inpatient unit. We adapted the merit for short-term setting, inpatient setting. So I think this is a brief overview of what we have done and doing.
Thank you very much, Elenit. We have some time for discussion. Is there any comments or questions or responses to Elenit's interesting presentation of a whole bunch of fascinating data? And also done during an interesting dynamic time, the whole thing of COVID going on, and a very interesting situation to be trying to carry out clinical research.
Elenit, I had a question about emotional experience. and how that was expressed. Was it necessarily positive? I mean, I'm thinking of a positive emotional experience versus a negative, and even how to describe that. I mean, what was the emotional experience that you saw?
Yeah.
How did you measure it?
Okay, yeah, very interesting question. And Libby is the expert in this, because this is the project that you have led, Libby. So maybe you like to answer?
Yeah,
You're in.
I can try. So it is very important, and we actually are trying to separate the balance of emotions in another project. What we are talking about in emotional experience is generally we asked the clients after each session how much do they were involved in emotional expression. I felt I could express my emotions freely during this session without separating to specific emotions, but we do have other data regarding specific emotions of both clients, therapists, and another interesting, I think, a point of view, how did the therapist guess or what did they think about the perceived the emotions of their clients? So we can check empathic accuracy and all kind of questions regarding specific emotions, and it is another future project of our.
Okay.
Yeah.
Thank you.
But Kelly, what were your thought that negative emotion, experiencing negative emotion will lead to other?
I don't know. I think it's just a question. It seems to me the negative experience would be maybe associated with a narrative episode that might be difficult, but also a relief. And I'm not sure how you would separate those, but just thinking of past therapies, those sessions in which the patient experienced some difficult feelings related to their story seem to be significant, but I don't know if they would necessarily say it was helpful or significant or not. You know, it just brings up questions, that's all. But that's what good research does.
I mean, I think that it matches, at least intuitively, unless I've misunderstood it, this our own experience that patients are able to name and describe pain and suffering.
Right.
And that then, I mean, it's not surprising that would be key to mastery. Because then there's a name, there's an idea of the challenge, and there's some sense of being able to understand and respond to it.
True. Yeah. Makes sense. Thank you.
Yeah, that kind of makes me curious, because I know the research says, and I've seen it in my own work, is that with insight is more pain, but is the client noticing that in the moment? Are they able to communicate that process is happening? That's an interesting question, Kelly. Yeah. I don't know the answer.
I think I'm thinking about other studies when we did see a difference in the balance of emotion when we examined our emotion recognition. So when people recognized positive emotions, usually the outcome, it's associated with good outcomes. But we did find in 2 studies that the recognition of negative emotion does not result in a good outcome. But I think that the main difference is that it's not an anonymous person that we don't know I mean, this is a safe environment in therapy, that we can express negative emotion, that we can name it, we can feel less confused because we are understanding something that happens to us. And I think these are good questions for us, Libby, to continue to look at and using maybe different emotion and tracing it. Yeah.
One thing that really strikes me as novel about this is the role of the therapist's mind. And it seems like here's this crucial thing, which is how to make our own, as therapists, how to make our own mental processes transparent to patients. And we often assume that they just are. And so I have the right thing to say to the person, I have the right knowledge of the person, I have the right technique. But that's different than how to make transparent what I'm thinking in the moment. And it seems like this is so essential in your data to outcome. I mean, and I think it also has a really nice match with our own continued explorations of the idea of intersubjectivity and how complicated that is for people with these conditions. And again, it's something we just assume is happening or transpiring.
I wonder if it's something that we are here from different countries. So I wonder if it's cultural based, because I don't know what you think, Libby, but I think that Israelis maybe tend to do more self-disclosure. It's more natural for us, I think. But I just talking with people from different countries. I don't know how it's in the States, in France. I don't know what you think about it, but I mean, for teaching or supervising therapists to use these elements, it's not so hard here. It's kind of natural in a way.
Yeah, I think there's much more variation as far as self-disclosure among therapists. And, you know, what you said about training makes me think of how often I struggle to get my supervisees to make disclosures and really use themselves as an actual tool and in an effective way. So I think that makes a lot of sense.
Yeah, I was similarly struck by that finding and thought that seemed really important, in part because it does map onto my experience. I think especially when I'm teaching merit to folks, I think that this is something that takes a while, at least maybe for people in the United States, maybe it's different in other places, to learn how to do it and do it comfortably. And I think not just like self-disclosure, but also like Paul was saying, like being transparent about their thoughts, and like offering their thoughts in a way that like can be scaffolded, that people can actually understand what they mean, because people do have low O and are struggling to form ideas about other people. I was curious, Eleni, you had a finding on there about there being a better outcome at the beginning of the next session if the therapist was inserting their mind. And I might have missed what the better outcome was. Was that related to therapeutic alliance?
If I don't know if you refer to the first project, we assessed both therapeutic alliance and a general well-being.
Okay.
Both.
So were those session evaluation questionnaires administered at the beginning and the end of sessions, or what was the timing of the implementation? So, yeah.
It was actually a pre-session, post-session for both client and therapists. We have, I think, a very, very rich picture and data that is yet to be discovered.
Yeah, that's fascinating.
Yeah, it's a trial. I think it's kind of a miracle we have this data and this trial, because and the miracle is because of Libby and Adi, the PhD students who ran the show, and because of the community clinic that we have here, who has all the necessary basic research facilities. So there is a routine monitoring here of session by session in the clinic. There are computers in the clinic, and therapists and clients they know that we are tracing the progress, and it's important to us to check also for clinical use, not only for research. So it's part of the routine work of the clinic here. So we just took this facility which exists and used it for the merit.
Yes, and it also allows us to compare, as you saw, our sample with other samples that are answering the same session-by-session questionnaire.
I just had a thought about the things related to the emotional experience and the effect of sharing like positive and negative emotions, and then also the inserting of the therapist's mind. And like, I don't know if it could get this granular in the analysis, depending on like how much was coded, like interaction by interaction, but it would just be interesting to know whether like a sharing of like a negative emotional kind of experience within a narrative, followed by like inserting the therapist's mind, or followed by evaluating like the progress, is part of what can help with those kinds of things, versus someone sharing a negative emotional experience and then that kind of being left there without really that intersubjective reflection or something like that.
We have some unpublished data. Bethany and I did this ages ago with Mary Vertinsky when she was a student with us. And if I remember it right, we asked the question, when does the patient become coherent in a session? And we used one of our patients who was profoundly disorganized. And we coded what happens right before he becomes coherent. And it was the expression of anger. That was the big winner, which makes me realize we've got to publish it someday. But I mean, I'm struck at that congruence, that when this guy could express rage, there then would be congruence of thought following that. And that was our observation from coding these therapy transcripts.
But
I also
wonder,
had go ahead.
I was just going to say, I wonder what he would say about that, to follow up on what Jackie said. I wonder his experience of that too, which would be interesting.
He actually saw like the deputy chief of the VA recently and told him I'm an alkie.
Told him
Alcoholic.
what did he say?
He told the deputy chief of staff at the VA that I'm an alcoholic.
That you're an alcoholic. Okay.
I know he said that. I was not drinking in session, but yes.
Okay.
No, but yeah, I think, yeah, this is an extremely rich database.
Mm-hmm.
I was also wondering what we think, or what some of the barriers are to inserting minds, if we talked about cultural barriers, and I was thinking of at least two, but I'm curious what the rest of you think. I mean, so one is, there's a sort of presumption that the therapist is a healthy one. And so we guard against disclosing any sort of reaction that might reveal that we're not the quote healthy one. But there's also this kind of risk management zeitgeist in the United States, in which I think there's a fear that if we start disclosing parts of our lives to our patients, that we'll start dating our patients and that all the boundaries will collapse. And so there's like a very sort of almost reactionary push to not to disclose personal information or personal reactions.
I notice a fear a lot in supervisees that they're going to make the person have more psychosis, that they're going to derail the person. That seems to emerge a lot when they're thinking about putting their thoughts into the session or self-disclosing.
I think it's like a free association. I think when I'm listening to it, it's like the part of the stigma of doing less is better with those people. We don't want to overwhelm them. We don't want to do too much. So let's just be very, very minimal with our intervention and not be too present. And I think it's like something that people, implicit knowledge that's passed from generation to generation in our profession. And it's something that we want to change because our presence is good for people.
I'm also thinking about the stances that we've talked about in therapy, and like Jay's paper on the supervisory stances, which also relates to the therapeutic stances, but that I think some folks come into therapy with the idea that that's not, we've kind of said this already, but like not the role. Like I'm the teacher, for example, and I'm here to pass on knowledge, but I'm not here to share my own experiences, because that's not what teachers do, so to speak, rather than it being this more equal relationship of two people sharing their minds and talking about what's in their minds and things like that.
I wonder if some of these things that we're noticing are also attributable to ways in which we as psychologists and the field has kind of moved towards trying to compete with more medicalized professions and medical professions. And so this idea of like what it means to be a doctor might also influence the extent to which people are or not, at least within like psychology, disclosing.
I think it also depends on the level of training in recovery-oriented practices. Because I think people who actually are trained to recovery-oriented practice and have this kind of practice in routinely will be more comfortable talking about their personal emotions or reactions following the patient discourse, because the relationship is far more collaborative, equal to equal, and facilitates that. I think it could be more difficult in situations where marked by an asymmetry and a differential in power between the two persons.
I do wonder, though, to what extent that is also cultural to some degree, because I think my impression of what we call recovery-oriented practice in the United States has a lot of different interpretations, and many of them are more of this hierarchical, like recovery means, you know, we'll get you back to work and we'll get you back to school, but, you know, not always necessarily adhering to, like you're saying, the relationship of equals and wanting to focus on the client's goals and things like that. So that may also be different country to country.
Can we have your help in thinking about the finding with regard to symptoms? How does those weekly session with people help them in reducing symptoms? What's the process that is taking place? Can we think about it? And negative symptoms apparently is more evident, but it's the total symptom scale that is significant. Or I might just add another, just to explain it better. The finding, to be more precise, Libby, correct me if I'm wrong, is that the merit group kept their level almost similar, but the control group were worse. And I guess it's because of during COVID and this crisis, worldwide crisis, so people got worse, but not the people who were engaged in treatment.
Where the baselines were troublingly different, though, no, between the two groups.
Yes, yeah, unexpectedly and without any reasons, just at random.
So I think one key thing to look at is, and this is something we've thought about with different groups as well, is what type of negative symptom. And there's been a really interesting finding, surprising across samples, that it's expressive negative symptoms that seem most tied to metacognition. So in the Danish study, which was a longitudinal study over 3 years, poor metacognition predicted higher levels of expressive negative symptoms 3 years later, regardless of initial negative symptoms. And there is a way to parse out expressive from experiential negative symptoms on the PANSS. And it also gets rid of some of the cognitive disorganization symptoms that get lumped into the rational scale. And I think if you're going to look at the findings on the general scale, though, I think that's such a mishmash of different symptoms. I want to know which ones. I mean, I want to know what are the ones, because I mean, I think some make more sense than others. Like I would be surprised if mannerisms and posturing changed.
Yeah, I agree with that thought, Paul. I was kind of thinking along the same lines. I mean, kind of thinking about the other findings there. If the person's able to come in, find a way to tolerate someone else's mind and express emotion in session, then it seems like there's a quite natural extension then that the more expressive negative symptoms would be better, or at least not worsen like the other group who maybe didn't have that opportunity.
And I think there's good evidence that, the expressive negative symptoms are mysterious because there isn't the same thing as empty experience. It just means you're opaque to the other person. The other person can't tell what I'm thinking or feeling or what's going on. And one again would think that with sense making, that might start to dissolve some. I think anything that shows that negative symptoms improve, regardless of whether you have a mismatched control group, is a remarkable finding.
Or are they more related to mastery than the other subscales? Because that's the one that was the most significant in maybe something between the improvement of metacognition is related to I'm not sure if it is an improvement in symptoms, but it's that we kept them in a steady level.
Well, there's a paper that Elanine and I have helped with. It's a larger international collaboration that merged, 15 different mass A studies with PANSS data. And it was really striking that it was negative symptoms was the big winner for the symptom correlate with metacognition. So, I think this really follows pretty carefully. And this included, data from all over the place and probably across many different cultures. One other thing, I would just add about the symptom question is, I'm forever perturbed by this, and this was a deeper problem that we experienced with the Dutch trial. And that is, you're asking if people are improving on something without determining ahead of time that they have a problem with it. So it's unlikely to get symptom change in symptom domain X if you have a significant number or even any number of people without any of those problems to begin with. So it's a sort of a strange question. You wouldn't ask if drug X reduces high blood pressure and have a sample where not everyone had high blood pressure. But I think there's really rich stuff here that is emerging in spite of the fact that there are going to be some people in this sample without high negative symptoms.
This is jumping around a little bit, Elanine and Libby, but I think you made mention of the fact that the session evaluation questions, I forget what you termed them, are used throughout the clinic. That this is just kind of standard practice throughout the clinic for all the clients who come in. They complete these pre and post session. That would seem like a fascinating data set to kind of contrast merit to other treatment as usual or what other things are going on in the clinic to see how what's going on in merit may be similar or different to other modalities of psychotherapy.
Yeah, so we have a first analysis of this that I just, one of the projects I presented, and we'll do additional ones. We also use the pre-treatment data to compare samples with interesting questions on emotion regulation, for example, or other variables. But it is an opportunity to compare groups. Yeah. We have in the clinic, we have people with emotional disorders and we have people who have no diagnosis at all. So it's also kind of a control group without diagnosis who gets psychotherapy.
Eleni, I'm curious about like the, in looking so closely at all the different merit elements, if you found any patterns in how well the therapist did in implementing merit, if there were certain elements that they had trouble consistently implementing in session.
Maybe I see you're smiling. You want?
Yeah, because we are planning to look at it next week with Gili. That's, you read our
It's on our
mind.
agenda. Yeah. We have our next data analysis meeting. This is the topic. We look at to see across each treatment to do like an average of the use of different elements to see how it relates to outcome. We're thinking a different way to address this. What do you what do you think is the best way to assess this question, to address it? What would you check?
I guess I'm not sure what the what all data you have. I guess you seem to have the like adherence scores session by session. Is that how you were looking at it?
Yeah, the TMAS each session. Yeah.
Yeah.
But who rated the TMAS? Was it rated by the therapist who did the session, or was it rated by other people reviewing the session?
No, it's a subjective therapist rating. Yeah, I think one of our questions is that, as I see it, the elements are supposed to synergetically act together. So I'm not sure what is the way to compute. What Jay asked, if, for example, there is a therapy where one element was missing, or how can we look at the whole picture of how they work together? Statistically, we're not sure yet how to check it.
I think this question sort of came up for me too when we were looking at the insertion of the therapist's mind, and another one I think like really relating to outcomes is like, are some of them like maybe inserting the therapist's mind like happening more often or happening more effectively? So I think that same kind of question came up for me, but I'm not exactly sure how to address that. Other than, I mean, I guess looking at count, for each session, which elements were met according to the therapist rating, and then doing some sort of co-varying, perhaps, I'm not sure.
Maybe we could, start with descriptive and see what do we do more. And maybe there are elements that our therapists tend to neglect, and maybe in other samples it's different. Maybe we can see cultural differences with regard to the different elements. I don't know.
A similar thought to that, Eleni, and was thinking about, I don't know exactly what the research question would be, but when you were talking about how like element 2 is not so difficult in Israel, like thinking about looking at qualitative differences in how, merit sessions look in different cultures. I'd be curious to know if there are certain elements that are more impactful kind of based on culture, or things that are easier for therapists. Again, like thinking about like how they approach therapy and think about what change means. So I think there's like a lot of research questions like rattling around in my mind, but I'd be really curious to do some qualitative work to kind of compare the actual transcripts of some of our sessions.
Let's do that. Do you have TMAS in a US sample for different sessions?
Yeah.
We can check TMAS and outcome in different culture, and do a nice comparison. It will be really nice. And it's not only if it's easier for therapists in different cultures, but also if it's better for the clients, because maybe for clients in different cultures, it's not so good that the therapist is sharing his thoughts, maybe because it will be strange or out of context, or I don't know what. I mean, Simona, you joined us lately, but I'll invite you in. Do Italian therapists tend to share their thoughts with their clients?
Yeah.
Yeah, I thought so.
Yeah, the quick answer, yes. No, I have a quite experience also applying this kind of intervention for people, for migrant during the 2015 migrant crisis and after that. So in my personal experience, it can be more tricky to have a behavioral intervention rather than more, I don't know, insertional therapist mind or intervention like that. I have had some problems maybe in some sub-Saharan groups, but we were treating not psychosis, more post-traumatic symptoms due to the migration for the asylum seekers. In that case, the use of experiential and group setting were well accepted, and so the possibility of involving other peers in the discussion during the group setting was very welcome. But if you want, I can share. We have some data also in terms of mass A, not a huge sample, but some people, especially with psychosis from different culture, also from Far East subject. But again, in my personal experience, I really had more problem in terms of I don't know, behavioral activation or more technique like that.
Yeah, I was curious if you ever looked at merit readings for peers. Can people hear me?
You sort of have a strange echo. At least I did.
I wonder if you could type your comments.
And the question of kind of the cultural interpretation or how different cultures might understand therapist self-disclosure is interesting. You know, because it's obviously what we do is all culturally grounded. And the extent to which that's seen as useful by different clients, and probably also the types of self-disclosure. You know, some would be more positive and useful than others.
That's a great question. We have not, so Ruthie had asked about peer counselors, and we have not jumped into that and wondered how that works. I mean, in our own clinic now, we have a quite exceptional peer counselor. And I would guess that part of his ability has involved both self-disclosure, but also his ability to think with people and to follow intuitively varied elements. This particular, peer counselor is really connected with pretty difficult people to connect to. We've shared sort of the zeitgeist, but he's not received formal merit training. I don't know. I mean, it's a complicated issue how that would overlap. Ruthie, do you have any hypotheses about it? I don't want to give you more typing, but I would love to know if you have guesses. Or anyone else for that matter, obviously.
I really love this point, Ruthie, and thinking about the merit group that Paul and I have been working on. I've been thinking a lot about having these other peers in the group add so much in terms of sharing their own disclosures, their reactions that they share. And it's just such a rich discussion that comes from it. So I really think these peer providers is such an interesting perspective and maybe untapped area that we could think about in regards to merit.
I mean, it definitely gets around the self-disclosure issue. I mean, it lands you right into that realm where you don't have to be the quote healthier person, because it's acknowledged that you've emerged from significant struggles. I'll mention, so this is another brand new thing that we've tried. Ashley has manualized a group approach for merit. It involves narrative elements and gathered data, and was just submitted for publication, if I'm not mistaken, like last week.
This makes me think of another struggle with inserting one's mind that has come up for me, at least, is like the decision in the moment of whether some self-disclosure is beneficial for the client or just beneficial for me. Because sometimes I just feel this desire to relate to people and communicate and stuff, but then in the moment I have to be thinking through that, is this just for my own benefit, or is it a mutual benefit? And I think in some cases that could depend on the client.
I've struggled with that too, Nancy, and I was wondering if that friction would be less so with peer providers, maybe it would be different, there'd be less overthinking it. Sometimes I feel like I kind of overthink that, wondering if this will be helpful, and so I just don't self-disclose in that moment. It's sort of a decision you have to make in the moment, like you're saying.
But I think we need to differentiate between different types of self-disclosure, because we can disclose personal information about ourselves, and it's completely different than disclosing our thoughts and emotions that are within the ongoing sessions.
Yeah, I agree. Excuse me, Elenit. There's a big difference between inserting one's mind and self-disclosing. To me, those are different things, and sometimes appropriate to self-disclose, but less so, I think, than inserting one's mind. And I think those are different. Maybe there's overlap, but I think it's important to clarify what we're talking about.
I do think that our colleague Jeremy right now is really actively thinking about some of this stuff. That several of the comments made me think of this new paper that he's working on, which is sort of about therapists taking risks. And I think it maybe gets at some of this desire to connect and whether we're trying to address our own emotional needs. But I think he's interested in at times using his own kind of irrationality and sharing that in a way that's, it's not just self-disclosing an autobiographical fact. It really is inserting his mind, but it's willing to also be quite confused or have a strange thought and insert that, which I think to some of the earlier comments, certainly trainees or early on in their career, psychologists, at least in the US, are quite discouraged from saying something that they haven't really thought out and just sort of letting it kind of tumble out and think with the person about it. So.
As we're talking about this, my mind keeps going back to Emily's point earlier too, about just thinking about what is our role. And that seems like that's so inherent in all of this, people sharing their minds. If your job is to be the therapist and you are the person of health and you're there to help somebody with their problems, then I think you are a lot less likely to just sort of share your mind or say something that isn't super well thought out. It seems like instead, what we're constantly trying to help people do differently is think about their job as a therapist is to think with someone as a consultant rather than some kind of expert who's going to control or give them the answers. And I don't know if that's just an American thing or if that's present in other cultures, but that seems like that's so related, these two ideas of why would you share your mind and like what is your position in the room? How do you think about yourself?
I think that for me, the findings of this element that show the meaning of using these elements, the effects of these elements, it's all about intersubjectivity, because when we are sharing our thoughts and emotion, we are present. And when someone else is present with us, our self-reflection increase. And this is supported by different developmental theories and educational theories. I mean, if someone else is thinking and reflecting in the presence of us, it helps us reflect, because it makes us more present in the presence of another that is present. So this is the rationale for me to use this. And when we are thinking whether to share our thoughts and emotion, of course, there is questions of timing and question of the specific clients, but we are considering it all the time. And this is something that we're doing in Merit and not in other therapies. We are always considering sharing and inserting our mind.
I think the degree to which, therapists do think about that probably would also have an effect on, how effective inserting your mind or self-disclosing is. Like going back to the peer point, I think of, I've seen peer specialists make the same disclosure to every single person that they've worked with. And so it's a disclosure, but it's not really specific to what the person needs or might be looking for.
I'm just sort of reflecting on it. In a prior career, I worked pretty heavily in a substance abuse treatment unit. And there's many counselors, but oftentimes their major qualification is that they have personal recovery experience. And simply the willy-nilly sharing of personal experiences and inputs and insights, I don't think was necessarily a very professional or very useful thing definitively. Sometimes it was, but other times it was, like others have said, it wasn't sufficiently, in my mind, oftentimes professionalized or contextualized or provided in a way that's going to be necessarily useful for that client at a given time.
I feel like we're making an argument for peer specialists being trained in therapy in like Merit and therapy to have like both of those kind of pieces.
There could also be at least an interpretation too of some of the deeper processes at play. I mean, it works against, again, just generic lots of support is what people need. People, they just need some sort of writing of injustice. And our colleague at Pathways, Kevin Rice, not Pathways, Fountain House, the clubhouse in New York, wrote a paper trying to argue that some of the foundational things that happen in clubhouses, which is to your point, Ruthie, some of these foundational things have a metacognitive nature. That is what Eleni just described. There's closeness to other people. And it's not just generic closeness. That was a great example of the person who just shares the same thing with everyone. It's like a Facebook post. It's not really personal. It's looking like we only have about 5 minutes left. So I don't know, should we talk about, I mean, this has been a fantastic discussion in my mind. It seems manifestly, perfect. Are there other thoughts about, anyone wants to share about what's useful going forward or lessons learned from this first attempt? the quarterly merit conference?
I think this discussion and the research and helps me to enhance my discussions with colleagues and in my work setting. I think that's the biggest benefit that I walk away from this with.
I really like the overall structure, how there's kind of more structure in the beginning and, you know, just open discussion towards the end. And I especially kind of like discussion of barriers for us of kind of delivering this merit therapy, but also I always think about implementation and others using this and making it more accessible. So I think some kind of discussion of barriers and facilitators to that in the larger group, because it's such a complicated thing and different clinics and different countries have kind of things to consider around that. So I think that could be a really good thing that all of us could discuss, of kind of expanding this to as many people as we can.
I thought the discussion was great, and really just appreciate time to see a number of you that don't see very often. So I think this is a really great idea. I'm glad we're doing this, Paul.
Thank you everyone for signing in, and thank you for those of us. Nice. Also great that we can see new faces. Julianne, thank you for joining us. And so, yeah, been a fantastic experience. I'm really glad we did this too, and I'm glad it was. I will confess, it was probably Reed who said, "Let's just get this started. It doesn't have to all be perfect and organized ahead of time." So, I will credit Reed in large part for making this finally come forth and not just be another good idea that we don't get.
Well,
Congratulations for the organization of this very interesting meeting and for also the website. It gave me the opportunity to see some people I usually cite a lot in my papers, but without never seeing actually really before. So it was a great opportunity to know each other. So thank you very much for that.
So I think we're right at 11:30. So shall we conclude? All right, thank you, everyone, again.
Thank you
Fantastic
all.
stuff.
Thank you all.
Very enjoyable and productive.
Thank you.